Part of what we like to do is at least do some good suboccipital palpation, and that's identifying some of the suboccipital muscles. Recent research has shown that these suboccipital muscles actually have what's called myodural bridging, which means that the muscles don't just originate from the bone and are enveloped in fascia and they have some nerves going through them, but they actually have bridging to the dura itself or connect to the dura. So sometimes if you get that cervicogenic headache that's unilateral, some of it might be that influence of the tension of the muscle if the person's always in a forward head posture, etc., affecting or causing the headache, or it's cervicogenic. In review, cervicogenic headaches are usually unilateral, tension headaches are usually bilateral when you're working on the cluster. So part of this is just looking to see if we can reproduce the pain the patient's coming in if they're having neck or facial pain when they're coming in. So what we want to do is identify the different muscles. Where the angle of the mandible is in the mastoid process. Because in between that angle of the mandible and mastoid process is the transverse process of C1. So if you can find the transverse process of C1, and then you start on the back of the occiput and slide down, that first bump you feel, that's C2. That's the spinous process of C2. So you're able to palpate the spinous process of C2, the transverse process of C1, you're off to the races because you can palpate all the suboccipital muscles at that point. What you can do is have him like push up into me here. If he contracts his trap and keep that muscle tight, we know that and then relax, we know the bound of the boundary of the suboccipital muscles is right underneath the traps. So if I am palpating, I know that I have all the different muscles that are going to attach to the neck, and I'll start laterally for the superior oblique, and the superior oblique will come from that lateral margin of the occiput down to the C1 transverse process. So I can get mid-belly and have him turn his head to the right for me and then to the left, and I can feel that muscle kick in when he turns to the left. So go ahead and turn to the left again, and I can feel that muscle kick in. So then you're looking to see if that reproduces symptoms. Inferior oblique, which has a decent amount of myodural bridging and the greater occipital nerve goes through it, runs from that transverse process of C1 to the spinous process of C2. So you can palpate along there, see if there's a trigger point, and again, have him rotate towards your fingers, and you can feel that muscle kick in, and you're looking for reproduction of pain. The rectus capitis posterior minor is just very midline, and remember, it goes basically from the occiput to C1. And the rectus capitis posterior major is a little bit more lateral and goes down to C2. The minor are a little bit more, run in more of an anterior posterior direction. For the purposes of this lab, I just want you to work on that superior oblique and inferior oblique. So it goes from the occiput to C1, transverse process and transverse process to the spinous process of C2. Those are the ones that we most commonly are dealing with, and you can have them rotate their head in order to reproduce it. For the major and minor, you can just have them do eye movement as well, so you can look up and see if you can palpate those muscles contracting. If you get on the obliques and have them turn their eyes to the right or left, you can kind of feel those muscles contract as well, because of the cervical ocular reflex to bring those muscles in. So that's just some basic surface anatomy. Then we'll just go to the stress tests. So for the stress tests, it's going to be pretty simple to do. I always start with traction because traction's the easiest thing. That if I do, that's your go-to treatment. So if the person's laying in neutral and you are at roughly C2 and your hand's on the occiput and I just lean back, there's going to be some traction. Now, anyone who's taken a class from me knows, go ahead and bend your legs. I like the patients typically in hook lying or pillows underneath. So what I would like you to do, if we're assessing traction, is have the patient in hook lying, get on the occiput, get on C2, and just have your hands there lightly. So I'm just lightly cupping up on the occiput, then my hand's here, and then I'll have him straighten his legs. And when he straightens his legs, I can feel some traction. And that gives feedback to my hand of, oh, that's how much I want to push. So go ahead and bend your knees again. And then I'll match that by leaning back. If we were going to involve a little bit more of the posterior ligamentous system and the tectorial membrane, I'll have you go into flexion. And I'm just using my arm here to guide the flexion a little bit. And I try not to manhandle. And then I lean back again to see how they respond. This should feel good. It shouldn't be irritating to them. If it is, they're a little bit more acute. You may want to use a collar or something like that.